Hello everyone and welcome to today's webinar about trends in higher education mental health, research and highlights. My name is Ron Goldman. I'm the co-founder and CEO of Kognito, and very happy to have you join us today and listen to a great panel of experts and have them share their recent research with you. A little bit of house cleaning before we get started. We are recording this presentation and we'll be sending you a link as well as a copy of the slides. All of you are in listen-only mode, but you could and please submit questions as we go through the webinar. We have about 20 minutes of just a discussion with the panelists once they're done with their brief presentation. So let's get started. A little bit about us, for those of you who are not familiar with Kognito, we are a health simulation company based here in New York City. We develop online role-play simulations that are really designed to help individuals such as faculty, students, and physicians on how to lead real-life conversations with people to improve social, emotional, and physical health. We do this by using a game technology and a simulation technology, so you can actually practice having these conversations with virtual students or patients, etc. In higher ed and mental health, we've done a lot of work. There's over 300 colleges that are currently using one or more of our simulations to train their faculty, staff, and students, and happy to have a few of our simulations listed in NRAP in the National Registry of Evidence-Based Programs and Practices. So today we have a great panel of experts. Each of them will be providing an overview over about 5 to 7 minutes about recent research, and then we'll go into a Q&A. We already have a nice number of questions that have been submitted, and please continue to submit questions as we go through this presentation. The panelists today, as you can see on your screen, from the left is Daniel Eisenberg, who's a professor of health management and policy in the School of Public Health at the University of Michigan. He's also the director of the Healthy Minds Network. Our second presenter is Miki Sharma, who's the director of the Office of the Student Life Counseling and Consultation Service at The Ohio State University. He's also the president of the AUCCCD. Our third panelist is my colleague Glenn Albright, who is a clinical psychologist and the co-founder and director of research here at Kognito. So let's begin. Daniel, would you like to take over?
Yes, thanks so much, Ron, and thank you for having me on this webinar. I'm just going to spend a few minutes showing some of our most recent data from the Healthy Minds Network. So to give a little context for our Healthy Minds Network and Healthy Minds study, my background's in economics, and the way I think about college student mental health is how can we invest most efficiently in mental health and success and well-being, everything that flows from mental health in student populations. So that's kind of the overarching question. And to get to that, the answers to that question, we start at the bottom of this chart with collecting descriptive population data, and that's what the Healthy Minds survey data is all about. And all throughout that process, we're looking to interact with practitioners, administrators, policymakers, and students to make sure the data are as relevant as possible. Our network has involved around 200 colleges and universities over the years, mostly in the United States, and around 200,000 student participants thus far. So you can see a map with the sites that have been part of the network, part of the study. And so some of our most recent data, a lot of the data I'll show you are from this past academic year, 2016-17. This chart shows, for example, that the prevalence of, so the percentage of students who screen for a likely depression case, which would be a 15+ score on the PHQ-9, it's 14%. And you can see similarly, anxiety, eating disorders, non-suicidal self-injury, suicidal ideation are all kind of in the range of 10 to 20%. And then cumulatively, there's 39% of students who have at least one of these apparent mental health conditions. At the same time, you see 42% of students are high on a flourishing scale. So you've got a lot of students on both ends of the mental health spectrum. We also see from our data that there does seem to be an uptick in mental health problems, at least some of the problems that we measure. And so, for example, suicidal ideation has gone up from 6% of students to 10% of students over the years in our data set, actually 11% in our most recent survey year. Mental health service use, as I think all of you know, has also increased quite a bit. So for example, in our most recent year, among students with one of the apparent mental health problems that I showed on a previous slide, it's about half who have received, 52% have received some mental health service, whether it's therapy or medication or both, in the previous year. And that's a clear upward trend. Those numbers were down in the range of 40% or lower in the early years of our study. Our survey, we've expanded it to cover a greater number of topics in depth. So the survey consists of a couple of core sections on mental health and service use and background characteristics. And then in addition, campuses that participate in the study can now select from this menu of topics that they want to cover in more depth. Topics such as persistence and retention, sleep, eating and body image, and so on. So with that expansion, we have some new data points that I wanted to highlight. For example, we look at we're looking at risk and protective factors that are associated with better or worse mental health. So sleep problems, as you would expect, looking at students with little or no apparent sleep problems, it's a fairly low prevalence of mental health problems among that group, 17%. By contrast, for students who are in the clinical or severe range of sleep problems, it's 88% who have an apparent mental health problem, such as depression or anxiety. Similarly, students who have experienced abuse or assault in the previous year have high prevalence of mental health problems. Students who are experiencing frequent financial stress. And then lastly, we have a resilience scale of psychological flexibility measure that's grounded in acceptance and commitment therapy, called the AAQ2. And for students who score high in flexibility, or in other words, low in avoidance, they have a low prevalence of mental health problems at 17%. But then students on the other end with high avoidance or low flexibility have a very high prevalence of mental health problems at 91%. Just the last couple of slides with some data. This one just to show you that when we ask students about their attitudes with respect to upstander or bystander behaviors, we ask them, how much do you agree with this statement? We're a campus where we look out for each other. You can see it's a fairly kind of dispersed distribution. You've got students who disagree, you've got a lot of students who agree with the statement, but I think there's clearly room for improvement in this area. I know that's part of what Kognito and programs of that kind are working on, is how can we make it a more supportive environment where people really are looking out for each other. Last bit of data here. This is a slide just to illustrate an economic case that we've helped institutions build with respect to their mental health services or programs by looking at how reducing depression can potentially increase student retention based on some of our research. And there are other studies that have looked at this relationship as well, and then translating that to economic gains in terms of tuition, revenue, and lifetime productivity or earnings for the students themselves. And so overall, the economic case does appear to be favorable, as these example numbers illustrate. So that's just a sampling of some of our recent data as well as some of our past data. I'm happy to follow up with any of you who want to learn more. And I thank you again for the opportunity to be part of the webinar. I look forward to the questions and discussion.
Great. Thank you very much, Daniel. Quick follow-up question. This came up when we did the webinar yesterday around this economic case. The question about how comfortable are the counseling directors, which are not normally economists, using a model like that to help justify the value that they bring? And have you seen more adoption of this among counseling directors?
Yeah, I mean, I actually, of course, maybe we're talking to a selected sample of directors who are especially interested in this kind of data and logic. But I think my sense is that there's quite a bit of comfort with the basic argument, and I think actually directors have been making it probably in some cases long before we came along with our research. So I think what we're doing really is just kind of trying to make it more specific to quantify this argument that I think a lot of people have already intuitively been interested in and have been making. And we also have heard from a number of schools that they are directly kind of taking the numbers that we're providing and presenting them to their higher administration, whether it's their president or provost or the board of regents, whoever kind of they feel like they need to make their case to for supporting student mental health with more resources.
Yeah, I agree. I mean, I can say from our experience of working with a lot of different colleges and universities that the minute you introduce this model, it really helps elevate the conversation above the counseling center to the VP of Student Affairs or the provost or even the president, and really shift the conversation from looking at the mental health as a cost center to really a resource to contribute even financially to the bottom line of the organization, which really changes how a lot of people at the top of the administration really look at mental health, especially if they don't really know the value of it and needs to be slightly educated on it. So we'll come back to this. There's already a few questions about this, but let me move on to our next presenter, Dr. Glenn Albright from Kognito. Glenn?
Thank you, Ron. One of the really nice things about being a researcher at Kognito is that there's a huge amount of data available. And that's the case with the baseline survey that we ran between February 2012 and June 2017. The survey involved 100 colleges and universities that were geographically dispersed around the United States. It included over 65,000 participants, slightly over 14,500 faculty and staff, and over 51,000 undergraduate students. All were going to take the Kognito mental health simulation, but first must have completed a pre-survey or a baseline survey, by which the results I'm reporting on today. So 50% of the students were mandated to take the survey. None of the faculty were, and most of those that were mandated were freshmen. So the survey really wanted to ask or find the answers to a few critical questions. The first one is, are faculty, staff, and students adequately prepared to support students? The second one, are they already connecting students to support services at sufficient levels? And lastly, do they think that this is part of the role on campus, that is, to support student mental health? In this next slide, the first three data points address how prepared learners are to help students in psychological distress. Now, we chose the attitudinal construct preparedness because, like behavioral intent or self-efficacy, it predicts behaviors, thus is preferred over knowledge items, which really don't do a good job at predicting future behaviors. So all three of these preparedness items are drawn from the validated 11-item Likert scale gatekeeper behavior survey that is available to anyone who wants to use it to assess the impact of their gatekeeper program. So the first item shows that 50+% of subjects reported that they are not adequately prepared to recognize when a student is exhibiting signs of psychological distress, including depression, anxiety, and thoughts of suicide. And you can see more specifically that 58% of those were faculty and staff and 51% undergraduate students. The second item shows that over 60% reported that they are not adequately prepared to approach an at-risk student to discuss their concern. And over 50% do not feel adequately prepared to recommend mental health support services. Now, if there's any good news to be had here, 87% reported that it is their part or their role as a faculty, staff, or student to connect students experiencing psychological distress to mental health services. And that included 95% of faculty and staff and 87% of students feeling that it is their role to do so. So this brings us to the behavioral data. Here, all students and faculty and staff at the pre-survey were asked in the prior 2 academic months, did you recognize any students exhibiting psychological distress, or did you approach and refer any students in psychological distress? And we see well over half, and 52%, did not recognize anybody in psychological distress, and 60% approached no one to have a discussion or made a referral. In this table below, you get a little bit more of a dissection where if you go down to the second item under faculty and staff, part-time faculty, we see that 61% did not approach or refer any student in the prior 2 academic months. And if you go down below that to students, you see, and not surprisingly, that 63.6% of freshmen identified no one or made attempts to refer. So this leads us to a few conclusions. That number one, faculty, staff, and students state that part of their role is to identify, talk to, and refer students in psychological distress to mental health support services, yet they feel that they're not adequately prepared to do so. The second conclusion, this is in terms of the behavioral data. The statistics show that the number of students being approached or referred to mental health services are far below the number of students in psychological distress. And lastly, academic institutions should really take advantage of the fact that faculty, staff, and students report that they want to assume the role of gatekeeper to help students, which in turn would connect more students to mental health support services. It would reduce stigma and support a positive mental health culture across the campus. Thank you.
Thank you, Glenn. Quick follow-up question for you. In the table that you talked about, where you're breaking down the students, for example, and the faculty. So an observation and a question. One, it's interesting to see the difference between full-time faculty and part-time. And knowing that there's more and more part-time adjunct professors, the fact that such a big difference of in their percentage do not identify anyone is kind of, I guess, concerning, because they're becoming more of a majority of the faculty, and yet they're not really being as active. But my question is about the students. So freshmen, I see 63% said that they have, in this case, approached no one. And then those numbers go down pretty significantly, in about 10% when you go to sophomore, junior, and senior class level. Any reason, any kind of theory about why that goes down in the second year?
That's a great question. I think freshmen have a huge job in getting used to going to a college environment. They don't quite understand the stresses that are involved. They're acclimating. They don't adequately understand the support services and how to access those support services. So a number of reasons, probably our other 2 panelists can respond to those even better than I can.
All right, thank you. Miki Sharma from The Ohio State University. And why don't we move on to you? You there?
Yes, I am. You can hear me?
Yes.
Hello? Okay, very good.
Yes,
I'm glad we don't have the same technology issues we had the other day. So happy to be here. I'm going to talk about some of the findings that we've gotten from the annual survey of AUCCCD, which is the Association for University and College Counseling Center Directors. So this is a professional association of individuals who have the same position as I across the country and across the world as counseling center directors, and we've got, including our emeriti, over 900 members, and 35 are outside of the United States. So we have been doing this survey of our membership for over 10 years now, and the survey has over 500 different items on it. It's done once a year, and it allows us to collect information to assist directors both in terms of policy protocol issues and information that can help directors best run a university counseling center, but also allows us to gather information about the students who seek services at the counseling center. And where we've evolved, as you can see, we had 529 respondents to our survey this past year, but this is far and away the largest sampling of counseling center directors in the world that occurs on an annual basis. So let's move to the next slide, please. What you have here is longitudinally looking at what is the most frequent concern that students come into the counseling center with. And what this graph demonstrates is it's evolved to that top line is anxiety. Depression is number 2, relationship concerns are number 3. If we go back in time, at 2010 is when depression and anxiety flipped, and anxiety became the number 1 presenting concern, depression number 2. Anxiety as a presenting concern continues to rise each year, as you can see that across time. Historically, depression had always been the number 1 concern that students brought into the counseling center, but that has flipped several years ago. And there's a number of reasons we can talk about later if we want to get into that as to why that is. But this, and I don't think this is a surprise to anyone in our audience today, but this just kind of gives you quantifying information to demonstrate that this is actually occurring in university counseling centers. And again, this sample size is of students who have come to the counseling center to receive treatment. This is not queries of your general student body in that way. Okay, so let's go to the next slide. So one of the things I want to highlight from our survey, this top point is significant, but what it highlights is that students are finding that if they use services from the counseling center, 72% are saying that it has helped their academic performance. This is a key finding. This is a key benefit for our students, and it really gets into, you know, the mission of any university counseling center being intertwined with the academic mission of the institution. Because with every counseling center, the excuse me, the goal is to help students be academically successful so they can graduate and launch into their career. That's why counseling centers exist on campuses. That next point there is that 92% of centers are not charging a fee for their services. So what centers are trying to do is be as accessible for students and make their programs, their services, the treatment they provide as accessible for students and reduce any barriers that are out there. Finances being one of those barriers, because a lot of us continue to see students who are struggling fiscally. This next slide looks at the use of any form of telepsychology or telemental health by university counseling centers. This past year, it was at 10% of the centers who responded to the survey are using some form of telepsychology. This has grown over time. If you look just back over the last 5 years, if we look back in time, it would be even lower. So this is, again, another way in which centers are offering new programs or services or new ways to reach students. This would be a way in which we can use technology in a friendly way to match students to meet their needs and help them get services to be successful. Next slide. We talked earlier, Daniel talked specifically about the use of finances and resources in the center. And we have seen some really significant growth in terms of new resources being added to centers across our membership. In the last year, there was 404 new positions added to counseling centers. The year before that, it was 202 positions. So just in the last couple of years, the number of brand new positions added to counseling centers doubled in just 1 year. In our survey last year, 42%, 42% of the directors who responded indicated that they had received new positions. And so while some centers have added one position at a time, we've also seen multiple centers excuse me, who have added multiple new positions simultaneously. So this is speaking to the university, your chief student affairs officer, your upper level administration, really making dedicated decisions, strategic decisions to increase the resources to the counseling center. Because another finding of our survey is that when you increase staff, the utilization of the counseling center goes up. Well, that can be very intuitive. It's important that we're able to demonstrate that by increasing staff, the number of students who access services increases as well. And then finally, that last point is indicating that with the increase, we have more centers who are able to offer psychiatric services on their campus as well. So this is indicating that students who are needing not just talk therapy, but are needing some type of medication management to best assist them with the struggles that they're having at that time. So I think, those of us in our association in this field have subjectively certainly seen more ads, more position openings across the country for positions in counseling centers. So we are hopeful that this trend will continue as the big winners when this happens are students on our campuses who are able to access services. And I think that's the last one.
Great, thank you very much. So we'll begin now a little bit of a panel discussion here with our panelists. There's a number of questions coming in. So let me start maybe quickly, Mickey, following up with you. A number of questions here about the telepsychology slide that you mentioned. We can see the increase. We talked about this a little bit yesterday, but maybe if you could share information about, first of all, are there certain types of schools that are adopting it more than others? And how are students reacting to it? Do you know, are students actually start preferring to do telepsychology than actually come in for an in-person?
So in terms of the use of telepsychology, I do think that we're going to see more of that at larger campuses where your students may be further from the campus. I think there's that. I think there's also a number of larger institutions that are looking to increase their online footprint with having more students who are taking courses online. I think we're seeing a little less of that, say, at a smaller private liberal arts school or a school where it's basically the entire student population is residential and everyone is right there on campus. We do find that students are making more requests for more online services. So a couple examples we've done on our campus here at Ohio State is moving to online scheduling for students' initial triage screening. This was something students requested. We went live with that last year. They've been very appreciative and they like that they have that. So 24 hours a day they can get online and schedule their first triage appointment to enter the system. We've developed an app at our center that any student can download at no cost. It has, in addition to connections to a lot of the resources on our website, also has a deep breathing and breath visualization, some other programs like that students can use to help manage stress and anxiety. They can do that within 5 minutes, say right before they're going to walk in and take an in-class examination. But again, I think all these things are opportunities to use technology in a student-friendly way and have a win-win situation.
Okay, great, thank you. Daniel, a few questions for you. First one is around stigma. Have you seen in your data stigma going up, going down, not changing? And do you have data that's student-specific or faculty-specific?
I guess I would say in our data, what we've seen is that stigma appears fairly low. And actually, it's been low from the time we started measuring it in 2005, 2007. So it's not to say that stigma has disappeared, and certainly it varies across different kind of student populations within the greater college population. But I think it's clear that, for example, when we ask questions to students like, how much do you agree with the statement, I think less of someone who's received mental health treatment, or I would accept someone who has received mental health treatment as a close friend. It's about 90+% who are endorsing the more positive, progressive attitude. And so I think that at least says that there isn't kind of the overt stigma that sort of we often traditionally think about. It might be that the stigma is more latent. It's not something that people would acknowledge, but maybe it's still kind of there on some level. But overall, I think the picture is that today's college students are very knowledgeable and very open to the idea of seeking help and using mental health services relative to, I think, what we have thought about in the past.
Mickey, do you want to comment on that?
Yeah, what I would add to Daniel's comments is that one of the ways I think that we've been successful in reducing stigma is you will find your counseling center staff doing work across the university. So going outside the center and reaching students where they are. Outreach programming, workshops, specific programming, at times targeting and being made specifically for our students of color or for international students, a couple groups that tend to be more concerned about coming to the counseling center. So this is why it's important for your counseling center staff not just to be in the center, but doing work across campus, connecting with other departments, working with other departments, and getting that buy-in and that connection and that collaboration work makes our offices more accessible for students also.
So follow-up, Daniel, to you. So if stigma is not that much of an issue, then what are the reasons that still a large percentage of students who are experiencing psychological distress do not go to the counseling center, do not get help?
Yeah, well, I guess in terms of stigma, I would add that stigma is kind of a complex, multi-dimensional concept. So, so I think maybe a better way to kind of summarize our findings is that stigma is maybe taking a different form than kind of the traditional notion. And what I mean by that is that when we actually ask in our survey, we ask students a question about why they have not received mental health services or why they might have received fewer services than they would otherwise, and they have a lot of different answers that they can check, and they can check all that apply. And some of the most commonly endorsed answers are, I don't have time, I think the problem will get better by itself, I have other sources of support, or I don't think my problems are serious enough to warrant seeking help. So you could call that a form of stigma. I guess I think of it as it's not necessarily kind of a intensely negative attitude about services, but it's maybe more of a lack of problem recognition or a lack of urgency. So I think that is kind of the way that I think about. I think there are a lot of people who are not seeking help who maybe are open to the idea, but are not taking action because it doesn't feel like an urgent or a necessary step for them to take.
Okay, thank you. Glenn, a question for you. You showed data about students, but there's a question about whether there's been differences in self-reported preparedness level of students, not just by class, but also by gender, race, or cultural affiliation. Can you talk a little bit more about that? Because I know that you did collect that data. Could you share that?
Sure, I'll be glad to, but I just first want to weigh in a little bit on the stigma issue, and that I feel that stigma is quite a concern when you look at student veterans and also international students. I see that quite a bit at the college that I'm affiliated with. In terms of looking at preparedness based on race, we do have some very interesting data in terms of how, as a composite variable, being comprised of how prepared you are to identify, approach, and talk to and refer to mental health support services, we show that Native Hawaiians and Pacific Islanders have the highest degree of preparedness, and slightly below that would be American Indians, Alaska Natives, and below that, and grouped quite closely together, are whites and Hispanics, and then below that are Asian populations. So we are seeing a different starting point in terms of preparedness based on race.
So what you found is that, in this case, Asian students report the lowest level of preparedness, and the highest is reported by Native Hawaiian and Pacific Islanders. Interesting. Mickey, let me come back to you. There's a number of questions here relating to what you referred to in your slide in terms of institutions investing more in counseling centers. So two questions. One is around the use of master level counselors instead of just advisors that don't have necessarily mental health experience but are cheaper, as one of the questions here refers to, on whether you have an opinion on which one makes more sense for a counseling center to invest in. And the other one has to do with connecting the health center, the more kind of the medical health center, with the mental health counseling center into one entity, one point of entry for the student. If you could just answer both of those, and we'll take it from there as a few additional questions relating to this.
So the first question seems to be asking about the various mental health disciplines, master's level providers, doctoral level providers, and I think that one of the changes we've seen is a diversification across counseling centers in terms of the types of providers that are in the center. I think this is a great thing to diversify the providers that you have. In our center, we have psychologists, psychiatrists, clinical counselors, social workers. We've had marriage family therapists in the past as well. We have trainees in all those disciplines. Each discipline brings its unique perspective. We've got some providers who are triage urgent specialists. We have providers who are care managers, and we're finding that the folks who fit best in that position have a background in community mental health and tend to be social workers or maybe clinical counselors, because their training, their background, how they conceptualize the situation works really well. And so that's making sure that you have a team approach and everybody's working effectively together. So I think you can have a win-win situation there. Your second question about counseling and health and that one door in terms of where a student comes in and enters for services on your campus, I think what is best here is that each institution determines what is the right model, what is the right approach for that particular school. What I mean here is how we do things at Ohio State with 60,000 students on the main campus is different than probably how you're going to do things at a campus of 5,000 students or a campus of 20,000 students. When it comes to counseling and health, what is important is collaboration. Collaboration is more important than integration or merging. What I mean is you can live in the same building and not work well together. You can live in different buildings and work very effectively together. So it's about making sure that your counseling and health staff are working most effectively together, and both are able to see and respect the culture of the other operation. And finally, I'd add that what we found is when you've got two separate operations and they're put together, that's going to work most effectively if time and care is put into the process through how you combine those two situations, those two different departments, versus just trying to do it as fast as possible.
Okay, thank you. So building on that, Daniel, a question for you. One of the reasons why more schools have been kind of combining the two is because they want to implement universal mental health screening, right? That no matter if you come in for a headache or whatever, we will screen you for mental health at the same time. Are you in favor of that strategy as a researcher, that you think that doing universal screening of students, whether in the health center or maybe just kind of mandating that it's done, is that something that you think is something that schools should look into, that's going to help?
Yeah, well, I think the kind of the lessons from the screening research is that it's sort of obvious in retrospect is that screening is effective and cost effective when it links effectively to evidence-based to effective services, which might sound like a trivial statement, but as I think those of you in practice know, it's not trivial to get someone with a positive screen to actually attend a service that's going to be effective and get them to have the continuity of care that's going to produce good outcomes consistently. So some of you might be familiar with the National College Depression Partnership, which has done some great work kind of helping colleges and universities integrate more effectively, not necessarily, as Mickey said, not necessarily integrate in terms of location or even in terms of administrative processes, but more about the collaboration and the continuity that kind of follows the screening. So I think when all of that can be done, which is not simple, then screening clearly has benefits, clinical benefits, and at a reasonable cost.
Mickey, do you have anything to add on this question?
Yeah, no, I agree with what Daniel is saying. Is, you know, implementing any type of screening, you know, in a particular office, anything that is going to help us cast a wider safety net and make sure that we're catching a student who has a particular concern and then getting them connected to the right resource on campus.
Yeah, and I will add to that. You know, the problem is that if you just do the screening, and as Daniel said, without immediately connecting those who screen positive to services, you may just be creating even more anxiety among the person who's just been screened positive. And if, you know, there's no help or support being offered immediately to that individual, we may achieve nothing in that sense. So it has to really be connected to more than just use a self-screening tool. If you screen positive, hopefully you'll come and get some help. Question for you, Glenn, around training. So there's a few questions here about who should be trained. We can agree that the answer should be everyone who needs to know about mental health. Everyone needs to know about how to best approach someone that they are concerned about, how to motivate them to seek help. But is there a list of priorities? Should certain schools, if they cannot train everybody in the community, should they first go to students? Should they first go to faculty? Should they first go to staff? Should schools look at it that way if they cannot afford or have the capacity to train everyone?
That's a hard question to answer, but intuitively I'm going to students. Students are incredibly good at talking to each other, and they're insightful, and if with a little bit of training and self-confidence and knowing what questions to ask and how to ask them, and where to refer fellow students, I think they can be a real critical part of answering questions on campus about getting students to help. And then I would go with faculty and staff. But that's the order I would put. I would go students first.
Thank you. Daniel, a question on one of your slides where you provided data on what students whether they agreed or disagreed with the statement that we are a campus where we look out for each other. So the question here is those who disagree, right? You have about 40% who agree or strongly agree, and about 60 that somewhat agree to strongly disagree with that statement on their campus. Is that really a criticism by the students on the campus, that as if they think those who are running mental health on the campus or the school themselves is not caring or not communicating that they should care, or is that a self-criticism on themselves?
Yeah, that question, of course, sorry, something just happened to my screen, but hopefully it's fine there. Can you still hear me?
Yes.
Okay, good. Yeah, I mean, that question could be interpreted either way, and I'm sure it's a mix of the two. Students kind of acknowledging that they and their peers maybe are not supporting each other enough, and then also that they're not feeling like the institution, meaning the the administration and the staff and faculty, maybe are not as supportive as they'd like. We actually have some other questions that break it out a little bit more. So we ask questions like, do you agree with whether my institution has mental health as a priority, the wording something along those lines. And again, I think it's a similar distribution of responses. So you've got maybe half the people agreeing and half the people disagreeing. So I think it's both a critique of the institutions and the environment that they create, as well as an acknowledgement that it's also up to the students. They have an important role in their community. Also, I just wanted to make sure that Mickey can see the M on my sweatshirt because he was complimenting that yesterday, so I wore it down.
Can I respond to that, Ron?
Yes, please.
So, I'm going to talk about the community, but before I get to, those of you in the audience probably don't know that Daniel's on the other side of the pond right now. He's over in France, so I can't see anything over there, so I don't see anything as far as I'm concerned. But, okay, so getting on to the community piece. Research has demonstrated that when someone feels a part of a community, then that person is less likely to do violence in that community. And this is significant as we unfortunately continue to see acts of violence impacting college campuses all over the place. So a sense of community can be a residence hall floor. It can be the whole residence hall. It can be a student group. It can be a Greek organization. It can be the entire campus. But this is where I think things like school spirit, student groups, organizations, activities, the more we get students connected, the better it is for their retention, their academic success, and their mental health well-being. So a student who comes to the Counseling Center with symptoms of depression may be feeling isolated. So part of the treatment can also be about how we get that student connected to different places on campus, with an academic study group, anything, with their department major. And that's something that's going to help them. And that's why we want our counseling centers to be integrated within the fabric of the institution.
Great, thank you. Glenn, a question for you. One of the data points that you mentioned indicated that 87% of faculty, staff, and students say that they feel that it's part of their role to connect students experiencing psychological distress with mental health services. Did that surprise you that it's a pretty high number? It was 95% for faculty, 87% for the students. Was that a surprise? Do you feel as a faculty member yourself that has changed over the years?
Yes, it did surprise me. And Daniel, I think your data kind of alluded to that might be a little bit of a surprise to you also, and a delightful surprise because students are apparently, over the years, in my experience of 35 years of teaching, are paying more attention to their psychological health. They do understand more and more the impact of stress, and you have more outreach on the part of counseling centers coming into the classroom and talking to classes about services available. You have more people addressing issues that are important to students. There's more psychoeducation that's going on within the colleges and universities. So it delightfully does surprise me that it's that percentage, and as I kind of alluded to before, I hope that institutions take advantage of that, because if you know that there are faculty and staff that are ready and willing to become, gatekeepers to help fellow students, that is golden, and I would take advantage of it now in today's environment. I mean, it's obviously really important.
Great, thank you. Mickey, a question for you, and I think you'll like this one. The question is about what are kind of the key mistakes that counseling directors do that you recommend that they really try to avoid as they aim to improve mental health on campus? Are there certain things that you see maybe too often that you really want counseling centers to pay attention to make sure that they don't do?
So, Ron, what I'd say, instead of key mistakes, I'm going to talk about a key opportunity. And so, as we look at continuing to increase resources to a counseling center, as I demonstrated, we've seen more of that in the last couple of years. An effective way for a counseling center director to make this justification, make this rationale, on their particular campus is to involve the student voice, is to involve other departments. Meet with other student leaders on your campus and get them on board, because on a lot of campuses, the student voice is going to carry a lot of weight. And it's one thing if the counseling center director is saying, we need more resources in the counseling center. It's another thing if student leaders, the president, vice president of your student government association are making that same statement. If the staff in the residence halls, the staff in the health service are making that same statement. So combining everyone's voice to really solidify and justify the proposal, the argument that the counseling center director is making.
Yeah, and this, sorry, there was another question here about who should be involved in creating the mission and the goals for the counseling center. And I think you're answering that question as well, that
yes.
really everyone should be involved.
Right. Yeah. Yeah, when you think about, right, the mission, the goals of the counseling center should fit and should flow from your student affairs or student life mission, which should flow from your university's mission. This gets back to finding ways to help students be academically successful. But if you're looking at a mission statement, a vision statement, it would certainly behoove you to include the perspective of campus partners and students on that. Run some focus group, what do people think, and make sure that you're including those voices to ensure that you're creating mission, vision statements, strategic goals that align with the overall university.
Great, thank you. Daniel, a question for you in terms of, have you seen any changes in the data as you're hearing back from students in the last year, some questions on whether the recent election or other kind of socio-economic kind of conditions have really changed any of the answers? Are you seeing any of a positive or a negative effect of recent events, even in certain areas of the country that have suffered hurricanes, etc.?
Well, we're good. I don't have results yet, but I think in the coming months, over the course of this academic year, I'll have a lot more to share on that, because we're asking those exact questions ourselves, and we're actually we got some funding from the University of Michigan to do a project specifically focused on kind of looking at the current mental health of and also related factors such as sense of belonging, experiences of discrimination, and campus climate for students of color, for students from immigrant families, particularly for students who might be kind of most affected by some of the current political environment or other kind of social issues that have been in turmoil. So we'll have a lot to say on that in the next year or so. Sarah Abelson is a name some of you might recognize because she had a leading role in Active Minds for many years. She's still involved with them, but she's her main occupation at the moment is a PhD student at Michigan, and she's actually, for her dissertation work, focusing on these issues and kind of leading that arm of our research.
Great, thank you. Glenn, a question about medical students and other type of health profession students. Do you have any data that you have collected that you can share? Are you seeing different responses for medical students in terms of even kind of preparedness or interest or willingness to engage in this?
The answer to me is actually quite surprising, because we did have a large cohort of medical students in this pre-survey, and surprisingly, even though medical students report increased stress, demands on time, impact on social life, and so on, in the survey, in the preparedness items that we were talking about, they were less prepared than any other group to engage in gatekeeper skills, that is, to being able to identify, talk to, and refer students in distress. So it's really quite surprising to me. Maybe some of the panelists can have some insight on why they think that might be the case.
Daniel, Mickey, any kind of comments on this, which is kind of surprising data?
I'll have to think more about that one.
Go ahead, Daniel.
Oh no, I said I need to think more about that. I don't have an answer. Doesn't come right to mind. Sorry.
Okay. Yeah, that's okay. All right, we're almost out of time. I have one quick question, Mickey, for you. Pretty specific one on ratio between staffing and students. Any kind of best practices that you suggest to counseling directors as they want to make sure that they are well staffed to support students?
So the most often cited ratio comes from IACCCCD, which is the International Association of Counseling Services, which indicates you should have one full-time therapist to every 1,000 or 1,500 students, and that does not include trainees. The other factors I would encourage folks to keep in mind with regards to that is the utilization of the counseling center. So on average, the range is usually between 7 to 12% of the student body that seeks clinical services. However, that range and that percentage goes higher for smaller schools, smaller private schools, where we have some institutions that have over 20% of the student body using the counseling service on an annual basis. In a situation like that, you're going to need a better ratio than 1 to 1,000, 1 to 1,500. You tend to see larger public schools where the utilization percentage is going to be at a lower level.
Okay, great, thank you. So I want to thank everyone for joining today. Thank you for our panelists. Thank you for all of you that attended. And I hope you found this interesting. And we'll have recorded this webinar, and we'll follow up shortly with a copy of the slides as well as of the recording. You can see the contact information of our panelists on the screen. And they have agreed to receive emails from you if you have any follow-up questions. And those of you who submitted questions and we have not responded, we'll do that by email. So thank you very much. Have a great day, and thank you for joining.